Okay, we are at about 3 minutes after the hour. Hopefully that's allowed folks to transition between events and they are able to join in and hear the entirety of the presentation. So my name is Michelle Hager. I'm the managing partner of Blue Sierras Consulting. This presentation is recording. So if by chance you have to drop at certain points, you can always go back and listen to this recording on our website. And we'll also share that on social media as well. And you can share that with your colleagues as needed. Today's webinar is the future of telehealth, the new normal. We all know that in this age of pandemic, we have all been doing things differently, and we don't know what the next steps will be, the future will be. So today I am joined by two wonderful guests, and we'll talk about what we think the future of telehealth will be and what that new normal will look like. Next slide. So the three guests that I have today are Frank Seitz, the Vice President of Connected Care Operations from Jefferson Health, and Lauren Faison, the Administrator of Population Health and Telemedicine at Tallahassee Memorial. Welcome, Frank and Lauren.
Thanks, Michelle. Thanks for having us.
Thank you so much. Looking forward to the conversation.
Great, great. Thank you so much for being here. Next slide, please. So in terms of telehealth adoption, we know that pre-COVID, this is a screen grab or a data from Definitive Healthcare, that the level of adoption statistics for telehealth were roughly 200,000, 500,000, et cetera, depending on the types of groups that you were individual organizations were a part of, whether you're a physician office or a hospital. Typically in the ambulatory area, of course, there were some inpatient visits, but when we speak about the ambulatory work that we see today, the numbers were not really even approaching 1 million by any stretch. But on the other side of this, you can see that just from March 1st to April 1st, there were over 1.4 million texts, emails, messages, video conferencing, video visits, video conferencing visits, and that the volume was somewhere in the neighborhood of 37 times what it was previously. So many folks were adopting telehealth. We're seeing more usage of it. Everybody's being more comfortable with it. Patients and physicians and their practices were far more willing to embrace online scheduling platforms as well as online video visit platforms. And then patients were asking to utilize them, obviously with the fear or potential of going into an office, and that they are, you know, with the pandemic itself, and then obviously wanting to even self-schedule their appointments. And I should say at the top of this that if you do have questions along the way, please add those into the chat, and we will ask those at the end of the presentation, and we'll allow time for questions at the end. But in terms of the adoption of telehealth, just skyrocketing off the charts. Next slide, please. A couple of articles that I saw and there have been rolling around in the telehealth world in the last few weeks, months, is these two. So one in Forbes, that Forbes is now saying 5 reasons why telehealth is here to stay. So a magazine at that level, at that stature, noticing telehealth, talking about why it's here to stay. We already knew there was a tremendous investment in telehealth, and that we were seeing capital investments from various types of investment companies, et cetera, and convergence in the market, et cetera. But then we also see Seema Verna and her latest interviews and testimonies on the Hill that she can't imagine going back, and that she's calling for expanded use of telehealth after COVID-19. This is huge for those of us that know telehealth industry and have seen the pushback that we've had from CMS and the Congressional Budget Office, et cetera. So we know that trends are moving in the right direction and moving moving forward. In terms of volume that you have experienced, Frank and Lauren, at your individual organizations, knowing that this adoption, the not going back approach to this, tell me a little bit about how that has affected your organization. What types of the stories that you know of at your organizations, the volumes that you have had. Frank, do you want to start with that?
Yeah, sure. Thank you. So, in our organization, we've been preparing for this for years. Over the course of time, some of our colleagues on the call, who are in telehealth has hit their heads against the wall for years about how do we get volume and how do we get paid for it and how do we have sustainability. And it only took a pandemic that overnight we were able to scale, and thankfully we were set up to do so, and we scaled to 30-fold what our normal daily volumes were. And I think for us, it was, there's some hiccups along with that. But, for us, it was a matter of, not how we were going to do it, but when we were going to do it. We just didn't anticipate it was going to be a COVID event.
Yeah, right. We had that instigator of the pandemic. Exactly. Is that true for you as well, Lauren?
Oh, yes. I'm sorry that it took a pandemic to have all my dreams come true, but many of the things I've been asking for internally that, were kept put off, and we would have meetings and not much would get accomplished. We too had been working on the infrastructure, but just kept getting stuck. We weren't doing a lot of billing for telehealth because Florida is not super friendly with reimbursement. We don't have parity legislation yet. But suddenly, within 2 days, I got every resource I ever needed, from the EMR to the billing folks to the clinical documentation folks. And within 6 weeks, we went from pennies we were billing out for telemedicine to $3.2 million in visits and 39 clinics, 4 rural hospitals, and I had over 600 users actively using telemedicine across our enterprise. And it suddenly became, by necessity, those barriers didn't seem as big as they did weeks before. And so I totally agree with the no going back principle, that now that the consumers, our patients, and our providers have actually done it and gotten their hands dirty in this, they don't want it to go away. And so we're really trying to harness all that good feedback and, really work on trying to maintain the reimbursement and to keep it as part of our, tool in the toolbox in serving our patients.
Absolutely. Absolutely. Well, that's great. I think that both of you have done exemplary jobs in reaching your patients and addressing the needs that we've had during the COVID pandemic, and also preparing for the future. And it's great, as you said, it's too bad that caused all of your dreams to come true. And I'm sure that's ringing true for many of the folks across the country that are doing telehealth. So what does the future of this look like? Next slide, please. So during the pandemic, we know that Glenda the Good Witch, who we just saw come up, was there, waved her magic wand, and then ding dong, the witch is dead. We have all of those, barriers that we had related to telehealth just gone. We saw waivers come up. We saw barriers related to payment gone. We saw compliant technology waivers, so that we didn't see the barrier related to some of the quick moving technologies that we might be able to use, mobile technologies that we might be able to use, and of course the geographic site restrictions. So of these waivers that we've seen during the declaration of emergency, which of these do you think will, and others, these are just those that I've picked up, but which of those, what do you think will continue and which will be rolled back? Lauren, you want to take that one first?
Yeah, I think, well, there's what I hope and what I think. I hope that we maintain the ability to see patients in their homes or wherever they are. I have a feeling we will go back to having certain approved presenting sites. Again, I hope that's not true. And for us, the biggest concern right now is the reimbursement, because again, we're not in a parity state, and many of the commercial payers were following the lead of CMS and agreeing to reimburse during this emergency period, but now they're starting to set end dates, and they're all over the map of who's it stopping when, and we're trying to keep track of which payer says they're going to stop reimbursing when. And I think that the pressure needs to be put on the commercial payers to keep reimbursing, but I think some won't. They don't want to pay for things they don't have to. So I'm afraid that that's going to close some doors for us. But I am confident that some of this good will continue on, and at least, because COVID-19 hasn't gone away, and so we still need to be able to treat patients safely, whether that's in an urban area or a rural area, it shouldn't matter. And so we've been able to serve both effectively, and so I think that the expanded codes will stay in place, but I do worry about the presenting site locations and the geographic restrictions.
I worry about the geographic restrictions as well, and I also worry about, I don't know that I worry about it, but I do think that my personal opinion is the HIPAA non-compliant technologies will roll back as well. So we won't see folks utilizing, FaceTime and Skype and just, various technologies that we saw pop up. Yeah. Frank, what's your perspective?
You can go all over the place. I think, I don't think that we're going to see, I think from a controlled substance standpoint, it's going to roll back to where we were. I think that the non-HIPAA technology will roll back as well. I think that there's too many providers in the space already with HIPAA compliant technologies that can satisfy the need. I think that where people, I look at this as COVID and COVID 2.0. When COVID 2.0 hits, providers and organizations are going to need to be in a position to be able to think about different technologies that are HIPAA compliant and that will be, for the future and will set us up for the future. I think the challenges there are that I think that, organizations and providers, are going to take a wait and see approach based on the payer status. We see that right now, even with the providers of telehealth, the big companies that are out there providing, their software and some level of physician practice engagement. And, they're waiting to see, what types of changes are they going to make to their own platforms, based on payer parity and coverage parity. I practice in a state where, we have primarily in Pennsylvania, where we don't have either a coverage parity or payer parity. And, to the point that Lauren was speaking about, we're already starting to see that the providers, we see some providers that want to continue this ongoing. We see others that want to roll this back, primarily if they already have large contracts with those vendors that are out there to provide services. And while we don't have necessarily in that model a continuity of care model with any said academic medical center or hospital system, what we're seeing now is that they want to push people back into whatever per member per month contracts they have in place prior to COVID. So I see that as a big barrier in whether or not you start to see people. We can say that telehealth is here to stay, but if the payer model doesn't follow along with that, I think you're going to see some people that are still yet a little bit tentative and sit back and wait for the next tweet that says that we're going to be able to use whatever technology suits our needs in that moment.
Yeah, I completely agree. I think that that's true. The parity is going to be key, but I do take heart. I do look positively when we see SEMA Vernon Day, which there's no going back. We know that the CBO has always said, the challenges, we think this is just going to be an overwhelming demand. People are just going to call their doctors and talk to their doctors for random things and, for, various, not necessarily, primary reasons to talk to your doctor, et cetera. And there would just be this massive volume and overuse. Well, now we've seen what that would look like, and they certainly have the claims data to be able to show what would that look like. So I think we'll see the CBO models actually be refined as a result of that. that even though we may have seen heightened use just because of the fact that we have people concerned if I have COVID symptoms or not, but now we can look at that and take the percentage of that essentially and be able to put that into those CBO models. So I'm positive, I'm hopeful that with that support from SEMA that we will see that payment model move forward. Next slide, please.
Michelle, can I just make one more comment about the technology? That actually hurt us more than helped us, because we already had HIPAA. We only supported internally HIPAA compliant technology, but my providers were jumping ship left and right to start using FaceTime because it was easier. Well, that still that to me is a liability issue, and so now I got to get them all back on the on the platform we wanted them to use in the first place. So I actually think, I mean, if we're providing healthcare, we should be doing it in a HIPAA compliant way, period. And so that part, I'm actually hope it does go back to some extent, because it kind of disrupted everything for everybody. And you're telling patients 5 different ways you might connect with them. Whereas within our region, if we all agree on how we're going to connect, I think that's easier for patients. But you know, we as a hospital system worried about our liability. I'm not going to be pushing out FaceTime. We need to be using, like Jim said, there's a bunch of other options that work just like FaceTime that are HIPAA compliant. And so I think that one, would be okay.
Right. Yes, I agree. I think, you know, and Frank said this too about the DEA, the controlled substance. I don't think that we're going to see going forward outside of the pandemic with the declaration of emergency that we can, you know, dispense and prescribe controlled substances without having, you know, some kind of a face-to-face visit under normal circumstances. And we know the opioid element of that was starting to loosen up a little bit for the obvious reasons there. But for the other controlled substances, I think you're going to continue to have to see, you know, patients face-to-face in order to be able to get those controlled substances. And I agree, we're hearing the same thing on the technology side, that don't give them Skype because we can't take it back out of their hands. We've given them, this
Right.
candy, and it's not healthy and it's not good. And so, point well taken. Thank you, Lauren. Next slide. So during this time, we've seen a lot of grants happen. FCC has come in, FEMA has come in. We now see an opening up of the USDA REST grant through July 13th, I think is the deadline for that. So lots and lots of money has now been poured into telehealth to help ease the costs related to adoption of technology in particular, or the purchase of technology and expansion of networks, et cetera, in particular. And what is your advice as folks that have just emerged into this market out of necessity and didn't have established programs like the two of you? What's your advice to those grant recipients in terms of how they utilize that grant and continue to move their programs forward in a wise way? Lauren, you want to take that one first?
Yeah, so we have always felt like we were operating on a grant, even though we didn't have one, because we had to beg, borrow, and steal to make our telemedicine program really come to life, because there wasn't a lot of revenue opportunity because of reimbursement challenges. But I think it is very easy. I saw every big vendor in the telemedicine market offering FCC grant webinars, and it was very, everybody thought it was them doing the grant, because obviously they wanted you to write them into the grant. And I see a lot of people pay for things they don't need in the telemedicine space, and it's very easy to get kind of courted by these big companies, and they have these easy solutions, and it's only going to cost you X amount $1,000 to set it up. Where really we've done it very inexpensively, and there's a lot of things that you can scale up. So I would say to start very small and scale up as needed. But really all you need is HIPAA compliant technology and some peripherals. You don't need these big services, and these things are going to cost you $200,000 just to set up. And I'm actually amazed. And when you say you're with a hospital, suddenly the price tag quadruples, that you don't need some of those solutions. And so we've been able to do it very inexpensively. And where you should invest your time and resources is in the planning and in the making sure your clinical protocols and your billing requirements and everything are in place. That's a much heavier lift. And so while it's cool to buy the technology and all the gadgets, where you really need to pay attention to is your deployment and your implementation, and making sure that everyone is well trained, and just because I'm a doctor and suddenly you give me Skype doesn't mean I know everything I need to know about telemedicine, and making sure that you're following all the codes and billing appropriately and all of that sort of thing. I've been saying this for the beginning of time, and vendors probably hate me for saying it, but I just think people way overspend on the technology, and then they get it and they unpack the boxes and go, well, what do I do with this now? And so really investing on that implementation period and training is huge.
Yeah, devil's in the details for sure. And I've seen many programs that have iPads on an IV pole and or other types of mobile technology that have worked in a lot of different areas. And Frank, what's your take on that?
I mean, from our perspective, we spend 90% of our time on workflow development and implementation, and education for our providers on how to do it. I mean, Lauren's right. You can hand them Skype on a stick, but the reality is that it's a skill. It's a newly developed skill that most of our providers haven't received during their training, their formal, medical training. And that's something that we have to really think about when we engage in providers. We need to be really thoughtful about how we educate our providers. We need to be really thoughtful about, what are the ups and downs. And then, you need to develop modules in education that supports that and sets the expectation for your enterprise or health system for how you want to see people provide the care to your patients. For another area, for the folks who have received the grants is that, take a quality approach to it. Take a really fundamental, solid approach to how you measure, track, and report on the outcomes for which you've received the money and for which you're implementing telehealth. The National Quality Forum, several years ago put out, a measures framework, that spoke about access to care, care effectiveness, patient experience, clinician experience. And, it might be a good time, especially for organizations that's received a grant that are, somewhat new to telehealth. It might be good to find some buddies and friends out there and partner in how you want to present your data, and present what things you're looking for that's going to be beneficial. And it might just be worth tying it to the NQF's measures framework. I would tell you that, everybody is in a rush, and this is just the world according to Frank here. Everybody's in a rush to do independent research with an N of 60 patients and try to push this into some, journal. I think that we're at a time where we really need to think about multi-site research and multi-site data reporting on how we influence, the payers and the politicians on how to support, payer parity and coverage parity, and how to look at this about having some compacts that go across state lines. And I think that where we have the data and where we report that in a systematic way, I think we will start to now push it further than just having an impetus, which was COVID.
I love that. I think this collaboration and research is a great idea. Thank you. Next slide, please. So you, in your organizations, probably adopted some new processes, and in addition, we may need some new processes added. I know we just did a recent radio show where Dr. Kraviter talked about this new webside manner that we need to talk about. We aren't necessarily going to be at the bedside or with the patient, so we need to now have a new type of way of interacting with those patients. So website is the term that he's coining, which I think is great. What new processes did you develop in the pandemic, and what do you think still needs to be adopted? Frank?
I think the new processes, which wasn't really a new process, although I could tell you that, starting early in January 6th, we were already talking about what is our redundant processes as it relates to telehealth. One of the concerns we had was, if all of our clinical practices went to adopt a telehealth model, would our systems be able to handle that volume? Would our servers be able to handle the volume? So for us, it was a lot about building redundant processes. I think that's absolutely key. We spoke a lot about website manner with our providers. We've trained thousands over the last 5 years. We trained 1,700 providers up until COVID, and then trained another close to 1,000 providers after COVID. you always have an adoption rate of a third, and a third. And we've really focused a lot on, think about this. Think about what your proper eye contact is and how you position your webcam versus your laptop. Your laptop, if you've ever spoken to people, 90% of the time, folks on a laptop, you're looking up their nostril as opposed to someone who has a webcam at the top of their monitor. It's simple things like that. As far as what we had to adopt, we had to get people to think differently about their skills, about how they provided that care. For us, it was really around adopting a quick ability to scale up in that volume. I think like many of the people that are on this call, we were able to get to a 30-fold increase, but boy, it wasn't without some sleepless nights and really hitting some bumps in the road. And I think that, the real adoptions that you have to kind of get people in your own organizations to think about is, how do you roll with the bumps? And is it the end of the world? I mean, we tried to compare telehealth adoption to normal in-person adoption, which is always in my mind the wrong comparison. I think the comparison that you have to convince your leadership in your organizations as you adopt telehealth is that is a telehealth visit better than a no visit? And that's something that we've really, much of our work in trying to get widespread adoption is how we focused our messaging.
That's a really good point. I know Judd Hollander, Dr. Judd Hollander that works with you always talks about why are we comparing a telehealth visit to a face-to-face visit and actually creating a standard that's higher for telehealth and saying, well, it should be as good or better than a telehealth visit. And in fact, it's not that at all. It's the difference between care at all and, no care and some care via telehealth. So that's a really good point. Lauren, anything to add to that?
Well, I also like the website manner. We've kind of play around with the term that I saw somewhere in some article about the telemedicate, and I thought that was a funny one too, but it really is about how do you connect with the patient a different way. And for us, it's really about maintaining that hybrid model of when is it appropriate for a telehealth visit or when should you bring the patient into the clinic. And that depends by the specialty. It depends on what they're trying to accomplish with that patient. And so we worked really hard and still working with the practices to figure out where does it make sense for them to really push out a telehealth service versus really needing the patients to come in the clinic. And when you talk about no patients, not getting a visit at all, we actually, our big homeless shelter was very proactive, and they started putting people in 3 different hotels. We were housing 400 people to keep so they could distance, somewhat in hotels. So we put an MA with a telemedicine device, and she would go out to each hotel on a different day, go somewhere else, and we were still seeing patients and still being able to address their health needs without them coming to the ER. And so I think looking at those opportunities and continuing to look across the enterprise, where can this be a tool to help increase access, grow market share, provide services, because I think, and somebody asked the question about affordability, I think there's going to come a time where consumers say, I'd rather pay cash for that visit and get it at work with my door shut and see the provider virtually than go through my insurance, because people want it when they want it and they're going to want to access it. So I think it's balancing, obviously empowering the clinical provider to determine when it's appropriate, but also balancing that consumer demand. And we had to do a lot of infrastructure. We had to, instead of this being a little side project we were doing, for high-risk patients, it is part of every conversation that we are having about any strategy, any kind of approaches we're having internally. And that's been a culture shift. So it's happened very quickly, but now maintaining that momentum will be a very purposeful effort.
Yeah, where you had to struggle to get on leadership calendar to talk to the CEO. There's no challenge with that. They're asking you to meet with them now. Yes. I love that homeless shelter story. I know that you've had, homeless stories before in terms of the program that you have, which is fantastic in taking care of those patients. And we're going to talk a little bit about the socioeconomic impact of having technology being almost a primary modality for delivering care, but even as it expands over time. So hold that thought. Next slide, just talking about technology and how, next slide, please. talking about technology and how we can push the technology vendors to start to adopt and innovate, because we know that the technology we have today is good and we're all able to do good work, and maybe we can't see what the future is, but what is the innovation that we see today that we still have to have in telehealth, so that we can even take even better care of these patients and that we can really integrate this into the care delivery model. Frank, you want to start with that one?
Sure. I think, during COVID at its height, right, when we were seeing hundreds of patients a day with our on-demand direct-to-consumer platform, I think one of the challenges that we were running into is now that Medicare and Medicaid, was covered for this, our platforms weren't ready to handle that. We didn't have a way to identify whether somebody, in the way that we were positioned to identify if someone had a coverage that they should have had bypassed straight through to a physician. We've spoken with our vendor, and we've realized that other vendors are challenged with this as well, around trying to get to a real-time eligibility where we can find that in on-demand platforms without having to put a human factor, a medical assistant or a registrar is the first step before you get to the provider. That's something that we didn't want to have in our program. And we wanted the patient to be able to get it straight through. I think what I'm hearing from vendors in general is we're not really sure we want to invest in that right at this moment. And so we know better that this is going to be something that's going to stick and stay. And then you have to imagine that there's, lots of dollars and lots of man hours to engineer that to be able to, get to a real-time eligibility. I think ultimately we're all striving for better integration with our telehealth platforms,
Yeah.
ours. And, I think that, the clunkiness that we were tolerant of prior to COVID, I don't believe that people are going to be so tolerant to in the future. And I think that that's where, as organizations, we need to work with our EMR vendors and with our telehealth vendors to streamline that and to find some better synergies that way.
Absolutely. Yeah, that's a really good point. Integration's always been a point for me, the interoperability, all the work and time we spent with meaningful use. And we don't want to create something completely outside of that, but we know that we can't always integrate every single thing, but that's a really good point. Anything to add to that one, Lauren?
No, I think it's just, make the availability of the products. Like so if you weren't quick enough to pull the trigger to purchase something, we have so many things that are still on back order, like digital stethoscopes and otoscopes and things that you may want to put in homes, and the pulse oximeters and things like that. There's just not enough supply. It went dry quick. It took us 2 months to get an order of webcams in, that kind of stuff. So really making sure that we sort of stockpile the materials we need and that they're readily available, and it's not something you have to pay somebody that's bought them from somebody else and you're upcharging, but to make these what the clinical peripherals we need available. It's been challenging.
No, that's a really good point. So even some of the gouging that we saw and heard about on the news in terms of PPE, we're seeing that even on the technical side with the pieces of technology that are needed to be able to do telehealth. Really good, interesting point. Next slide, please. So as we start to innovate and do more via technology, that's our kids at school, are they at home doing school? We're providing healthcare via technology. We're talking to our veterinarians via technology. We're ordering our groceries via technology. We're doing so much in this space that it is creating this digital divide, that there's an expense, as you noted, Lauren, that there's even gouging in these technology pieces, and this digital divide is going to continue to happen. And we already knew that we had socioeconomic impact of healthcare based on economic drivers, and we talk a lot, of course, in this industry about social determinants of health, and we know the data shows that zip code does, and it shouldn't, but it does in some cases, drive healthcare outcomes, and it has to do with the availability of healthcare. And we know that's bearing out in the pandemic and really shining a light on that. How do we how do we prevent the digital divide so that healthcare continues to be available and is improved for patients? How do we prevent this digital divide? And Lauren, I'm going to let you jump on that first. I know this is something that's near and dear to your heart and kind of every day when you talk about population health.
Absolutely. And I think it's funny because I think it's done just the opposite. I think the accessibility of using telehealth is actually helped with combat some of our health disparities, and it's much easier and affordable for us to plug in an access point throughout our community using telehealth than it is building more bricks and mortar buildings. And I think we as a health system have taken the onus of putting it where we need it, putting where we know the access is hard. It's all about community partnerships, and we're working with the zip code in our area that has the most challenging health statistics, and we're partnering with the church, and we throw a monitor and a webcam and a room, and suddenly you have access to healthcare where people can walk to it in a place that they trust in their community for pennies on the dollar, versus building a clinic or busing people or taking mobile clinics, that you can very inexpensively create these storefront access points working with community partners. And we've built a network that we're all using the same platform, which makes it really easy, with our FQHCs, with our homeless providers, with our nonprofits, with our primary care, and everybody can easily jump and find each other using the same technology. And it really it's brought us together more as a health community. And as a health system, I think it takes us to bring people to the table and figure out where those disparities are. And we work with our faith-based communities, we work with our nonprofit community to say, how can we help increase access to care in a way that people will receive it? Because you can build buildings and you can do all of those things, but when they can do it from their home, or they can walk next door and they can get on the cell phone, a lot of times they feel more comfortable with that, and they're actually willing to engage in the care than having to go to a hospital or a much more formal health clinic. And so I think that if we create those access points, people will come to it, and it really is making a big difference.
That's great. No, that's good. That's true. We've seen the accessibility really increase. One of the things that I have seen is the broadband issue coming to the forefront. I recently saw Jim Clyburn of South Carolina, in my state, who is very passionate about broadband access and increasing this as a utility in the same way that we do highways, et cetera. So this is getting a lot of attention. He's always been a supporter of it, but I think we've all seen that broadband access now needs to be increased in order to be able to reach everyone that needs to be reached. Because you're right, we had sort of school buses going around to put Wi-Fi out there, all sorts of different ways to just create Wi-Fi hotspots. What have you guys been doing differently, or what do you think about this digital divide, Frank?
It's interesting, and I agree with everything that you and Lauren are saying, but I'm going to kind of approach it from just a little bit of a different. So, we know we have data out there, right, that says that, I don't know, depending on your age group, there's anywhere from like 65 to, 85% of people have smartphone technologies. And we also have data that shows that most of our patients are having their video visits on their personal device of such. I want to be careful that we don't create the narrative that, while we are trying to get to, reducing these social determinants of health as far as access, that it's not meant for everybody. It's not going to solve the problem for everybody, right? So we know that the American Hospital Association talks about, 80% of, the issues tied for social determinants of health, are the physical environment, education, food insecurities, things like that. So the question is, what was your percentage of telehealth that you were engaged in your enterprises before? And what are you planning on for that to be going forward? You might not be able to solve for everybody's problem using technology, and this just might not be the technology for it. But I think that, the work that has to be done, there has to be better broadband. There has to be better ability to access for patients for that. But I'd be careful not to create a narrative that this should solve for all. And I'm not saying that anybody is saying that directly. But I think that, we have to think about what that looks like going forward. I've spoken with some chairs in our enterprise here where their thoughts are they're going to see 30% of their volume is going to be maintained on telehealth going forward. And if you think about that piece of it, prior to, it might have only been 1 to 3% in any given department. So the question is, do we need to solve for this for everybody? Maybe not. But I'd be careful to, I think about, rural versus urban care and access, right? So we have policies out there that really help us to get to the rural patients that are at a distance. But I would make the argument that 3 blocks from my hospital on the 4th floor of a walk-up is a bilateral amputee. And the only way that they're getting care is if they call 911 and say they had chest pain to come into the emergency department. And then, oh, by the way, they probably didn't really have chest pain. And at 1 o'clock, they had a family practice visit upstairs that we wheeled them upstairs for. So the access to care comes into many ways. The digital divide is very important, but I wouldn't forget about the policy divide as it relates to gaining access.
That's a great point. That's why you guys are on this panel and we're having this webinar. Those are great thoughts. And at that point, we have our next slide is some final thoughts. Now that we have some adoption, now that we see this massive momentum, that we have a community now that's moving forward with us that hasn't been in this community before. So what do we do, those of us that have been doing telehealth and have been trying to advance telehealth and move it forward, what can we do to help bring along adoption for others and bring along the early adopters that we're now seeing, and then also continue to advance telehealth? And I'll just say we're at 15 minutes before the end of it, and we have several questions. So we'll let our final thoughts for each of you be as brief as you can be and impactful. So Frank, you want to start?
Yeah, I would start with building continuity models within your enterprise. In our enterprise, we know that 70% of our patients, when we survey them, how they found out about telehealth, they said it was from their provider. So I think that where we can build continuity models with our providers, develop, telehealth facilitation programs, education, website manner, and other programs that support the providers. If you can support the providers and the providers feel comfortable with this, the patients will follow.
Really good point. Yep, exactly. And Lauren?
I would say we have never collectively told our story exceptionally well, that now we need to harness all of that good feedback from both the patients and the providers and the financials, and we have to tell the story. We have to, really maximize on the momentum we have right now and not let it go, the moments go by and people try to go back to the old way, and that we have to tell the story and put a lot of pressure on payers and regulators to really help us keep this safe method of care as an option, not for everything, but where it is appropriate, and empower the providers to make that decision. But I think telling the story is key.
Yes, absolutely. And I would only add that we need to make sure we keep the patient in mind, and how do we improve patient care as part of technology rather than just running towards that technology, because it's so much easier to do. So we have several questions that we have in our chat, and I think Judy's going to ask those questions to us.
Yeah.
Judy?
I am here. Okay, the first question is, with the huge numbers of people who have lost jobs and their insurance, do you think CMS will actually keep telehealth options because they provide a less expensive care option?
So I'll jump in real quick on that one. I personally do. I think CMS is going to keep the reimbursement. We know that across the country, there's various waves that are still happening and increases in cases. And so I do think you see that from Seema Verna. She's saying the genie's out of the bottle, we can't put it back in the bottle. So I do think we're going to see payment. The question, as we said earlier, is whether it'll be parity and whether or not it's going to cover all of the things that we really want it to cover. What do you think, Lauren and Frank?
I would just say that if they don't, the patients will, and that means they'll go to the ER when they don't need to. I think people will not have any other option but to do that. So I think we've got to make sure that we provide the care in an affordable way.
Yeah, and patients will find the least painful way to get what they need, and if they can get that through telehealth as the least costly model, as opposed to an ED visit, they will do that. The one thing I would caution is that for a lot of folks that live in non-payer parity states, they believe their medical expertise and their ability to assess patient and what their knowledge is just as valuable as if that patient was sitting in front of them. So, from a DRG perspective, it'll be interesting to see whether or not more states come to parity versus coverage.
Okay.
Yeah. Good point.
Okay, there was a little second part of that question is, if your health system is going to be on the hook for the underinsured, doesn't telehealth become a necessary tool to help manage costs?
Ooh.
Yeah, that's a good question. I might throw this to Lauren just because there's so much. She has a great program with the underserved, unless somebody wants to jump on that one. But my first thought is that if you're going to care for the underserved, we know that we have to create new models. We have to be very creative. I know from our own experience at Blue Cirrus, we've talked with organizations and have worked with organizations that are having challenges with patients that are both transient, homeless, language barriers, et cetera. So the whole underserved group, absolutely, you have to try new innovative ways. Either of you?
I just agree with what you said. I think it's absolutely. I mean, we've already been doing it and we've seen the return on investment. So I agree.
Yeah, I think it makes sense. It's an opportunity cost versus an opportunity loss. I mean, if you have an ability to leverage your resources, you're probably well served to create that type of a model. Again, I would caution that, what ends up happening is that for years, physicians continue to have phone visits where they don't get paid for. So I think that, in each of your communities, you need to be able to negotiate with your payers how to put such a program, in place that's going to support both the payers and the providers.
That's a good point. The payers are the trifecta in this game and in this team. So we need to make sure they're at the table as well. Do you have another question, Judy?
I do. Okay, on the subject of education, how can we provide better education of the role of telehealth in BSN, MSN, nurse practitioner, resident education to better prepare them to utilize telemedicine technology?
That's a great question. Frank, I'm going to let you touch on that first, as you guys have such a great program there at Jefferson Health.
Yeah, so thank you. So, I think it's coming. I know that I'm asked to guest lecture at multiple, different forums, throughout the year in trying to hit on this. I actually, the conversations and the education that we've developed has been around, we've developed CMEs around the physical exam. How do you assess a patient via telehealth? When we start telehealth, we go around the country trying to debunk the myths all the time where patients say, we don't want it. The doctors say it's not as good as an in-person visit. We can't examine the patient. It's not reimbursed. It's just too hard. And obviously with COVID, we debunked all those myths for the most part, right? So I think that it's less about the education on the technology. And I think it's around skill development on physical exam. I think it's around, how do you implement programs? How do you optimize your programs? And then how do you partner with the trifecta, as Michelle just spoke about, in getting people to, understand how to get the most out of your programs and how to deliver a quality program that fits in line with the NQF measures frameworks.
Yeah, Yep, absolutely. The technology is an area that we need to make sure that these. I think from an education perspective, I'd like to see my thoughts are going around as you talk through that, but I'd like to see the vendors helping as well and understanding that this isn't just the patient and the provider just simply talking. We need to make sure that we have, they need to go further than that. We need for them to understand from an education perspective that the clinicians need to be educated in these university settings, and that their technology needs to be available to residents and nursing students, et cetera, in these universities as well.
And I would say, Michelle, if I could just add one thing, folks
Mm-hmm.
have, we have a bit of a reprieve here, as we kind of come out of this first wave of COVID. If you're a conspiracy theorist, much like I am, COVID 2.0 is coming. So what you are doing now to educate, right now, we created modules in our organization. We created 4 different modules that speaks about the education, website manner, regulatory risk, compliance. What are the things you need to know about in order to do telehealth? And then, oh, by the way, how do you care for those patients doing telehealth? And, we did a ton of that ahead of time, which put us in a good place. I can tell you I'm refining a lot of that education now to meet the needs for what's the next phase of this going forward. So if you haven't done this in your organizations already, I urge you with every ounce of energy in my body, start doing that now. Start getting an approach, because when you get to this phase again in fall, if we see some type of surge, you don't want to be chasing your tail again. You'd rather be proactive than reactive in this area.
And
Very
Michelle,
good point. Very good. Mm-hmm.
I just wanted to add that prior to COVID, we have 3 residency programs: the internal medicine, family medicine, surgical residency. They were some of our biggest users of telemedicine, because we were using it to allow for education experiences, to really push the residents out into the community to see patients, and then they were being precepted virtually by their faculty. So they didn't have to be locked down to a clinic, and those were many of the providers that I had going out to homeless shelters, to community clinics, to provide care to diverse populations, which enhanced the quality of their education, but then they could be precepted to meet their requirements virtually, which was a great experience. And as we set up drive-through screening stations in our ERs and a community site, they were many of the workforce that manned those telehealth units that were seeing people in their vehicles as they drove through and assessing them, because they were some of my most experienced providers. And so you talk about an educational experience, being able to, participate in a pandemic like that. It took the burden off our ER providers. They were able to focus on the ERs, and they were, sitting in wherever they were, manning several different telehealth units across the community, screening patients for COVID tests. So I think it has been a wonderful tool for us, will continue to be a wonderful tool for us. And I think moving to the nursing education piece is definitely our next effort, because they play a vital role in making this all work.
Yes, absolutely. Yes, absolutely. Any other questions, Judy?
Yes, I have one technology question. Is the smartphone really effective for a telehealth visit, especially considering small screen, clarity, etc.?
So I'll take that. Yeah.
Go ahead, Lauren. Go ahead, Frank. Excuse me.
Yeah, I'm happy to take this one. So the reality is this. So yes, the answer is yes. The majority of our calls do happen on a cell phone. Clarity, you have to keep in mind, what is the objective of the telehealth visit? It's really to get to the next actionable step. So, just like if you walked into, your primary care office and they needed to get a chest x-ray or a lab, it's no different than, doing this on telehealth. There's very few things that you need the high fidelity of, the most, sophisticated high res, camera to roll with. I think as you become more experienced and more skilled with telehealth, even when you have things that do not go nearly as well as you would hope they would, you figure out how to roll with it, and you figure out how to manage to get to that actionable step.
I would agree with that.
Yep, absolutely. I talked to a doc just yesterday from one of the hot spots in the country, and said, I'm taught to listen to to the patient and what they say, and I'm also taught to listen to the body. And because I'm not with that patient, I can't necessarily listen to the body. So we have to kind of change the way we think about how am I going to be able to get the listening to the body as much as I possibly can. And it depends on that objective. What are you trying to accomplish and getting to that next step? And we have 2 minutes. Anything left, Judy?
I do. I just got one question here that snuck in under the wire here.
And I would tell you if I.
Yep. Go ahead, Frank.
No, the only thing I was going to say is, you get different information by doing a telehealth, visit with the patient on their phone, wherever they're at, because you learn from their environment as well. And it's something we really need to keep in mind, as you're listening for different things and assessing different things. You have to kind of put your clinical skills, to a different fit. Go ahead. I'm sorry. I think there's one other question.
No problem. Is there any evidence of disparity due to age? Older patients can be very challenged with telemedicine. This goes to your comments that it is not a one size fits all.
So I think I was the one that said no size fits all. So let me kind of take that at first. My 75-year-old mother is the worst candidate for telehealth until my 19-year-old daughter drives over with an iPad and says, Mom, look at this. We're going to talk with Dr. So-and-so at 3 o'clock on this. The reality is that, even while vendors try to make it one touch and make it as easy as possible for everyone, it isn't for everything. And it isn't for every condition that a patient has. So I, from an age perspective, we certainly see less people. We have data on this that are above the age of 65, but some of my highest utilizers overall are over the age of 75. I try not to cast, dispersions based on age or anything else, because I think that we found people on every age group that can, have an issue getting into a telehealth visit or not getting in.
Yep. Lauren?
No, I agree. I think it's amazing what people are willing to figure out when they don't want to go into a clinic because they don't feel safe. And so the adoption and having somebody in their house that could help them was very valuable. But I think also just their willingness and want to make it work was very important. So.
Yep. Where there's a will, there's a way.
Absolutely.
We are right on. That's right. We are right on time. Our contact information is up on the screen. I want to thank Frank and Lauren so much. You all are so generous with your time and your knowledge and your experience. Thank you so much for being here. This again will be recorded and it will be up on our website. So if you do want to reach out, you can contact these folks directly, and we really appreciate you being here. Thank you for taking the time out of your day to be on our webinar. We'll do another webinar next month. If you have a suggestion for a topic, we're always open, and we try to do those each month. Our radio show will be on our website as well, but we run that live out of Boston on June 18th. I think I'm going to get that wrong. June 18th at 9 o'clock. Thank you, Lauren. Thank you, Frank.
Thank you.